Hello, my name is Sarah Ama, and I will be presenting the case of recurrent STEMI in a young adult male with Factor V heterozygosity, casual or bystander. Factor V Leiden mutation results in the absence of a target cleavage site for protein C to degrade Factor V and 5A. It is associated with hypercoagulability and an increased risk of venous thromboembolism. Commonly, it will present as a DVT or a PE in the affected patients. The associated risk of arterial thrombosis in the setting of FVL remains controversial. Furthermore, it remains unclear how heterozygous carriers of the mutation are impacted. We report the case of a 30-year-old male who presented with the chief complaints of bilateral shoulder pain. At the time of presentation, he had a past medical history that was notable for a prior STEMI involving a thrombus to the distal LAD. It was treated with percutaneous transluminal coronary angioplasty in 2017. At that time, there was no clear identifiable cause that had been documented. Additionally, his mother had a history of several heart attacks at an early age. The patient did not have any personal or family history of any dyslipidemia. His labs were significant for a troponin reaching greater than 20,000 nanograms per liter. His EKG was notable for ST elevation in Lutz 2, 3, AVF, and V6 with reciprocal changes. He underwent a left heart catheterization that showed a 100% thrombotic lesion in the distal right coronary artery. There was additionally no evidence of dissection or plaque rupture. Our patient then underwent PTCA of the thrombotic RCA segment. His post-catheterization echocardiogram demonstrated a left ventricular ejection fraction of 64% and mild hypokinesis of the mid-inferior lateral wall. Hematology was consulted, and he underwent a hypercoagulability workup that was only remarkable for Factor V Leiden heterozygosity. The patient was discharged on aspirin and ticagrelor without any additional anticoagulation, due to the paucity of clinical data suggesting a benefit in the use of anticoagulation in patients who are heterozygous for the FVL mutation. Contributing to this decision was the fact that the patient, who was a young male, served as a police officer, did not want to be on anticoagulation unless there was clear data supporting its use. In conclusion, we report the case of a 30-year-old male who presented with STEMI in the setting of heterozygous FVL mutation. Notably, our patient did not have any other major cardiovascular risk factors or hypercoagulable conditions to explain his presentation. Current data shows no clear association between FVL and arterial thrombosis, let alone in heterozygous carriers of the mutation. However, associations with hyperhomocystinemia may set the stage. This case highlights the importance of better understanding this association to better guide management in the future regarding prevention of cardiovascular events and initiation of anticoagulation following acute coronary syndromes in this population. Thank you.